Good. Good morning. I did expand this just a little bit to include some early onset scoliosis, but otherwise we're basically talking about idiopathic scoliosis, early onset and adolescent. There's multiple subtypes of scoliosis. Under the idiopathic type, we have infantile, juvenile, and adolescent. There are other forms of scoliosis, of course, congenital, neuromuscular, and dysplastic type curves. Definition is a lateral curvature of the spine. Early onset scoliosis is an umbrella term for curves greater than 10 degrees in a child under the age of 5. And there is an idiopathic is a term used for curves that have no identifiable cause. Infantile curves are defined by the age of onset. So age of onset before 3 are infantile curves, 3 to 10 years are juvenile curves, and over 10 years of age we call adolescent idiopathic scoliosis. Infantile curves are generally benign curves. They're thought to be postural. There are certain cultural aspects that account for a higher incidence of idiopathic curves, such as in Great Britain, where there was a habit of sleeping on the same side, having the baby sleep on the same side, I should say. Hippocrates first made the connection between spinal deformity and pulmonary disease. Later, the terms kyphosis, lordosis, scoliosis were coined by Galen, and he actually started some rudimentary treatments. And historically, they've gone from traction devices to various types of braces, like I said, here's a femoral traction, rudimentary braces early on, another traction device. And this is something called the Sayer frame. Louis Sayer was a physician in New York who used to treat these curves by first hanging the child, getting correction, and then applying a plaster cast. And Sayer frames are still in use around the world for custom bracing. Although, of course, we're graduating towards CAD/CAM and computerized modeling, but this is still a good hands-on approach. Bracing's gone through its changes too, from metal and leather braces to today's plastics. Russell Hibbs did the first spinal fusion back in 1911. And you all know the term Harrington. Paul Harrington did his first spinal fusion in '62. This is one of the early fusions, and what it involved was osteotomizing the spinous process, folding it back onto the level below, and then obtaining a posterior fusion in that regard. These kids were then placed in casts and kept in the hospitals for upward of a year until they fused. The premise of the Harrington instrumentation is straight distraction. It was a straight rod with a hook above, a hook below, that just distracted the spine for correction. And so here's a ratchet device here, upward going hook here, downward going hook, and you'd ratchet this, you'd distract it intraoperatively and stretch the spine out. What was the problem with that? The problem was on the sagittal plane, it created a flat back, a straight back. And this change in sagittal alignment caused a significant and early degenerative process to occur just below the lower instrumented vertebra. And it was so common that it was coined a flat back syndrome. So there was a period of time where many people were coming back with severe degeneration and a flat back syndrome, which was a very difficult problem to treat surgically. In '82, Cottrell and Dubuisset from France introduced and developed their derotation system. This was a dual rod fixation system. It was segmental in that it attached to multiple segments, not just top and bottom. And it was the first system that dealt with the rotation and the sagittal plane deformity of the spine. So the Cottrell system initially was utilized hooks to attach to the spine. The rod was laid into the curve, and then the rod, so here it is, attached to the hooks, laid into the curve, if you will, and then derotated 90 degrees, so that what was scoliosis becomes kyphosis. So what was the curve in this direction becomes a posterior or a kyphotic curve. And then a second rod of a slightly different shape was placed, and that corrected the rotation and the sagittal plane deformity. Scoliosis occurs in about 3% of the population, but only a small percentage of those have curves greater than 30 degrees and will require treatment. So it's a very small percentage of the total scoliosis population that actually requires treatment. So most of what we do in the office is really monitoring and observation. It's an autosomal dominant disease, but very complex. There's been at least 50 genes associated with the onset of scoliosis and the progression of scoliosis. The expressivity is variable. And we don't know if there are any environmental factors that play into this. These kids are tall. They're physiologically younger with an earlier menarche. And there are various hormonal changes, such as increased growth hormone and somatomedin levels. We feel that the bone, tendon, muscle, nucleus are all normal, primarily normal, but they do undergo secondary changes, secondary to the to the abnormal loading on the curve. There is some abnormal myosin and ATPase activity that's been found. These kids neurologically have abnormal proprioception and vibratory sense. And interestingly, experimentally, if an animal's proprioceptive pathways, that is the dorsal columns, are disrupted, scoliosis results in greater than 90% of those animals. There are other neurologic changes. Vestibular function and balance is abnormal and is found in most patients with scoliosis. Statistically, there's no increase in back pain with patients who have scoliosis. Is there back pain? Yes, there is. Anecdotally, I find that kids who come with, who have scoliosis and then present with back pain during our follow-up period, frequently the back pain is associated with an increase in the curve size. And we also know that back pain is more common in adults and is the frequent indication for surgery in those adults. But in the adolescent and child, back pain needs to be investigated. And we'll get to that in a minute. We talk about pulmonary function as the complication of severe scoliosis. We start to measure pulmonary changes at about 60 degrees of curve. At 80 degrees, the vital capacity is decreased, and that can put stress on the heart, as you know, and cause cor pulmonale. Severe curves can shorten the lifespan of an individual. Now, why do we get changes in lung volume and cor pulmonale? And it really has to do with the fact that this is a three-dimensional disease with significant rotation of the spine. And in fact, some people feel that the rotation is the primary problem, not the lateral curvature. But they all are linked and go together. So we have rotation, sagittal plane, and coronal plane changes all happening at the same time because the motion of each segment is linked to the next segment. When that rotation occurs, the hemithorax on one side is severely decreased in volume. And this is a nice representation of how the chest wall changes in response to curves, particularly at the apex of that curve. Our examination and history taking should include questions regarding the neurologic symptoms and pain, because we're looking for all those other causes of scoliosis that could play. We want to know about where they are with their growth spurt and menarche, because that helps us with prediction, and we'll get to that in a moment. There are multiple causes of scoliosis and pain. These are some: osteoid osteoma, various spinal dysraphism problems. These include syringomyelias, tethered cords, diastomatomyelias, ono-Chiari malformations. Curves can occur from something that causes pain, like osteoid osteoma or herniated disc, and neurofibromatosis is a common example of a dysplastic curve. Connective tissue disorders and neurologic disorders tend to affect progression of the curve quite a bit. So we need to know if we're dealing with a low tone or a connective tissue issue. Look for things like sacral dimple and hairy patches. Look for neurologic findings. Other signs are rapid progression, left-sided curves, and large curves in male patients. These are indicators of possible dysraphism cases. Back pain can be mechanical from a large curve. It can be from dysraphism. So Chiaris frequently cause neck pain, headache, and can cause back pain. I see spondylolisthesis associated with scoliosis quite commonly. Herniated discs, rheumatologic. I've seen intra-abdominal or retroperitoneal problems cause both pain and curves. And don't forget the sagittal plane deformity like Sherman's kyphosis. Leg length discrepancy is present commonly, but does not cause the scoliosis. There are some studies that show that it can it can influence the direction of the curve, but is generally not causative. So check for non-structural curves, meaning that a pelvic obliquity can cause a curve in the lumbar spine seen on X-ray, but it may not be a structural scoliotic curve. Easiest way to determine that is to level off the pelvis and examine or do a picture, or very simply have the patient sit. Once they're sitting, their pelvis will be level, and you can determine whether you have a structural or a non-structural curve. More on back pain. Here's a 4-year-old female with a small lumbar curve, but if you look closely, there's no pedicle seen here. There's a cyst in the vertebra, cyst here. And on scan, she has a very large cystic structure in the pedicle and the vertebral body on the left side. It turned out to be a vascular anomaly, and I had it embolized here and did a resection and fusion here in this 4-year-old. This was done with a block of bone. And this is a posterior construct that I applied anteriorly due to the small size of the patient. Osteoblastoma. This is a patient who was treated for almost 2 years for this scoliosis, not by myself, of course, but treated with this curve with a brace. And when I saw her, she was complaining of daily and nightly back pain, and back pain that was worsening. And if you notice, the curve here is kind of funny. It's a very short curve. There's no curve above. It's straight below. So there's a little bit of an atypical nature to this curve. And sure enough, here's her tumor, very large, starting to compress the cord. And here's her tumor here. Big expansion into the spinal canal. And we resected her, fused those levels, and then there was still some anterior tumor that we knew was still there, but was not accessible. So I went in from the front with a thoracoscope and did the remaining resection thoracoscopically after she fused. I just want to check. You all hearing me and everything is still okay on your end?
Yes.
Okay, good. Other causes, this is a classic osteoid osteoma in the posterior elements. Again, it causes pain. The pain and spasm causes a curve. So don't be fooled. Neurofibromatosis comes in a variety of forms. There can be neurofibromas. There can be intraspinal dysplasia. The bottom line with neurofibromatosis is it can be very progressive. It generally requires early fusion and can sometimes require front and back fusion due to both its severity and progressive nature. I talked about spinal dysraphism. I find this a lot. I refer a lot of these to our neurosurgeons, and the majority do not affect the patient or our treatment. The majority of them are small and don't worsen, and the neurosurgeons just watch them. This happens to be a rather larger one. I can't remember a syrinx being drained neurosurgically in my practice in decades. I mean, it's very rare that it needs to be done, but we need to know it's there. You need to look at it. We need to know about dysraphic problems before surgery. It makes our surgery a little more risky. So we want to know, we want to evaluate, and the neurosurgeons or neurologists will follow these with MRIs to rule out any neoplastic origin of them. Here's a kid who came to me with neck and back pain, and she had night pain. Of course, night pain, you all know, is a red flag. She had a large curve. I actually put her in a brace, but after I got an MRI, turns out she has a large glioma. So the white is actually the tumor. This black is her spinal cord. This central, so all this white is her tumor, and this is cord. So it's really incredibly impressive, the size of this at this upper level. It's huge. The neurosurgeons resected it successfully, and her curve got better, and her pain went away. So not all scoliosis is structural. You gotta be very attentive to all the other causes of scoliosis. Let's get to exam and get away from back pain for a moment. What are the things we look at? Sometimes the kids have shoulder obliquities if the curve is high. This young lady's shoulders are nice and level. She is slightly off balance, meaning that her center sacral line falls to about here. She's a little bit off balance to the left. She has a large left thoracolumbar curve. You can see some scapular asymmetry, a crease or asymmetry to her waist. Very frequently, a girl like this will come in and say, one hip's higher than the other. And because when she looks in the mirror, it looks like her hip is higher. Sorry about that. Looks like her hip is higher, but it is not. Her pelvis is perfectly level. It's the curve above in the lumbar spine. Forward bending Adams test looks for the vertebral rotation that we talked about earlier. That is our tell. That's what we're screening for. There is a lot of variability between the amount of rotation and the size of the curve. So in general, this is not a good tool to follow curves or determine size of the curve. It's simply a screening tool. Look for rotation at the lumbar spine, thoracolumbar, upper thoracic, because you can have a curve high or low that's missed. It's not just the mid-thoracic that we're looking at. X-ray evaluation, of course, is the Cobb angle that I'm sure you're all familiar with. Which levels to choose is always a problem, but it's really very simple. Choose the level that is most tilted, the level that gives you the largest curve, okay? The level that is most tilted away from the horizontal. So that would be this level, and would be all the way up here. A lot of people would choose this one, thinking that's the end of the curve, but look, it really goes all the way up to this level. So that's the proper level over here. So choose the lines that give you the largest curve, largest Cobb angle, and those are the correct measurements. A quick way to determine skeletal maturity is with the Risser sign. As you know, in adolescence, the iliac apophysis forms over the iliac crest. It ossifies from front to back and then fuses at the end of adolescence. As it ossifies, we can characterize the degree of ossification. We divide the iliac crest into quadrants of 4, and we call an ossification center that goes up to the mid crest a Risser 2. This is a patient who is Risser 2. Risser 2 is roughly midpoint of adolescence. It's roughly the onset of a girl's menses. When we get up to about Risser 4 and Risser 5, we're dealing with skeletal mature individuals, and that relates to prognostication, which I'll be getting to right now. What are we trying to do with the treatment of scoliosis? We are trying to achieve a curve that the patient can live with the rest of their life. And that is all based on studying the natural history of scoliosis in untreated patients. So what we find is that if you look at these girls through adolescence and into adulthood, we find that large curves down here, 60-degree curves, are very progressive. They're very progressive when you're still growing. They're still very progressive as an adult, as a mature individual at 60 degrees. So these large curves are curves that we need to treat. When we go down to these smaller curves, curves less than 20 degrees are relatively stable regardless of age. But look, it's this curve right here, a young patient with a 20 to 30 degree curve. This is the individual that we can affect most with non-surgical treatments such as bracing. Once we get our big curves need to be fixed surgically. Big curves need to be fixed surgically. If we relate this to Risser sign, we see the same trend. Small curves less than 20 degrees are stable despite the fact that the individual is skeletally immature. That same skeletally immature, if they present with a large curve, that's a highly progressive curve. This curve needs to be treated. Okay, what are we trying to achieve? We're trying to achieve curves below 30 degrees. So, in summary, curves less than 30 degrees at skeletal maturity are stable. This is what we're trying to achieve. Curves greater than 50 degrees are progressive curves in a high incidence. These curves need to be fixed regardless of age. Okay, if you're skeletally immature, your curve is going to progress. If you're skeletally mature with a curve of 50 degrees, you have a high chance of progression. So it's these 30 to 40 degree curves that become a little bit gray as far as whether they're going to progress or not. So we do a lot of watching and observation in this age group to determine which curves are progressive and need treatment. Less than 25 degrees, we observe. Again, these are just sort of rules of thumb. When you treat scoliosis for a while, you really get a feel for who's progressing and who isn't. Greater than 25 degrees in a growing child, I probably should have added in a skeletally immature individual, we will brace, and large curves and progressive curves require treatment. Surgical treatment, I should say. This is a common Boston brace. I'm sure you're familiar with it. Most common brace, I would imagine, worldwide, but definitely in the United States. Other braces include the Providence night bending brace, the Rigaud-Chenot brace, which is a new derotation device. This is the Providence night bending brace. What it does is it overbends the curve while you're laying down. It's used only at night. It's actually a very effective, easily it is as effective as the Boston brace. But I find that it's effective for thoracolumbar and lumbar curves. Mid and upper thoracic curves, it does not do a good job. So I will use this brace if I have a nice lumbar curve. It's very effective for that. And the kids love just being in the brace nighttime only. They don't have to wear it during the day. This is one of my satisfied patients here. This is the Rigaud-Chenot. This is a brace that is computer designed. It is the way it's done is the patient is scanned with an iPad, really, and the computer remodels the brace or makes the brace with the spine in a corrected position. So the computer changes the shape of the spine and makes this brace. It derotates, it pulls the chest back here. You can't, hard to see, but here you can see the pelvis here, and the lumbar spine is derotated here, and then the chest comes in this direction, and this horn is pulling the chest back. So it is derotating as opposed to the Boston brace, which is just lumps and bumps and pads that just push. And this brace has been found to correct better than the Boston and have somewhat better results than the Boston. So this is my go-to brace for thoracic curves, and particularly the mid and upper thoracic curves it's effective for. Does bracing work? Bracing does work. There's multiple studies. I'm not going to go into all the studies regarding the bracing, but just here's a juvenile patient at 5 years of age in a Boston. So this is how the Boston works, right? These marks here, these wires, this is where the pads are. So the Boston brace grabs the pelvis and pushes on the apices, and we get 1, 2, 3 points of fixation, and we get some correction. This upper curve has to correct in response to correcting the lower. Now here's the same patient a few years later in a Rego, and look at the difference in correction. Tremendous. And that's why this brace tends to have better results. We brace this child through his childhood into adolescence, and here I recently took the child out of brace, and this is what he's left with now at skeletal maturity. So let's go back to Emily. We saw her before, and here's her curve. She has about a 70-degree curve, and it's a stiff curve. It doesn't want to bend out at all. Why do we do the bending? This is a surgical exercise in order to determine how low we need to extend our fusion. And we'll get into that. And this has to do with choosing levels. So I'm glad you're recording, because then this will be on the video for you to refer to. But couple of things here. Number one, we need to do the structural curve only. We don't need to operate on our flexible curves in general, and that's where your bending x-rays help determine which curve is structural and which isn't. This is obviously a thoracic curve, and these are compensatory curves above and below. So how low do we go? I find that this is a very accurate determination, which is the center sacral line. The vertebra that it bisects, significantly bisects, is a safe vertebra to stop at. So based on that, L2 would be our lower instrumented vertebra here. When it comes to upper, it has to do with the shoulder obliquity, which I apologize you can't really see here, but if shoulders tilt into the curve, we need to go up to the level that is parallel to that curve, and that's generally L4. Why? Because if you take that L4 vertebra and level it off, the shoulders will level off along with it. They're parallel. If your shoulders are oblique in this direction, in other words, tilting away from the apex of the curve, you're going to have to go up to T2. Did I say L2, L3 before? I meant thoracic. Go up to T2 and tilt those shoulders upwards. And you'll see some of that. I think I have some cases. The neutral vertebra, center sacral line, that's a good curve, good level to stop at. You can more safely go to the stable vertebra. If you don't, what if you end your curve here at 12, end your fusion here at 12 or 1? Well, you're going to have a lumbar imbalance that remains, because this curve is going to want to remain. Is that clear to everybody? I mean, I guess. Once again, let's go back to the CAT scan. What are we trying to do surgically? Well, we're trying to take this side, this pedicle of the vertebra, and we want to move it posteriorly and move it laterally, and that'll derotate this apical segment. In order to do so, we need to contour our rods. We need to consider how stiff the curve is. We need to consider the sagittal balance and what it looks like, how much change in the kyphosis and lordosis we have. And the shape of our rod will determine what our final construct and what the spine will look like afterwards. However, that all depends on what material and diameter, in other words, how stiff the rod is. We are constantly dealing with rod bend out. That is a rod that whose shape gets changed by the stiffness of the curve. The right and left side of the spine is different. Your rods should not match. The concave, in general, the concave rod is bent more, will bend out more, and takes larger loads than the convex side. And we'll get into that. So stiffer curves require greater force. Greater force will require more shape in the rod. It will require metals and rod size that is stiffer. And stiff rods require better fixation to the spine. So we want to anticipate how much change, how much bend out we're going to get based on the stiffness of the spine. If we have a very stiff spine and we're concerned about that, we may need to do multiple posterior osteotomies to loosen up the spine. So anticipate the change that you expect, and this is the final shape of the rod we want. Overbend in order to get this. Loosen up the spine in order to get this. Techniques, a translation technique. Let me back up. Many times I'm asked, what technique do you use to correct a spine? And my answer to them is I use them all, because there are elements in almost every fusion that require multiple techniques depending on the level and the type of curve you're working on. So you may have sagittal plane deformities that require lever action. We may have a severe curve that requires translation, meaning we put the rod in place and we have to, one by one, bring the vertebra to the rod. And then we put our second rod in, and we may be pushing down on the apex with that. This would be a lever technique. And then we connect the rods together. So sorry, my mouse keeps moving, I think. So translate the spine over to the rod, lever the spine in place. Again, what are we trying to do? Well, we want to overbend the concave rod, bring that concave pedicle up to the rod, expect a little bit of bend out, and then push down on the convexity in order to further correct the derotation. One of the nice, as I said, you have to increase your fixation to the spine if you're doing a very large correction. Pedicle screws are weakest in straight pullout. They're great for rotation, side to side, up and down. These Dacron bands are sublaminar devices that are great in translating posteriorly, and they can aid in this translation process, particularly if you're trying to correct kyphosis. So sometimes we'll use hybrid constructs. Sometimes I'll use these bands to reinforce a screw that's starting to pull out. It's a good tool to have in your armamentarium, and it's a good device to have on the back table whenever you're doing these cases and pulling screws out. It is extremely powerful at moving the spine posteriorly up to the rod. A very commonly, and probably the most common technique that does the majority of the work, is derotation. When I say derotation, I mean rod derotation, not direct vertebral rotation. They are different. Rod derotation is the following, and this is the Cottrell-Dubosset technique, where the rod is attached to the spine in the curve, and then the rod is rotated. And I'm going to show you all this. So our concave rod is overbent, attached to the spine, and then derotated. Again, just another view. Okay, concave rod, translate the spine over, or drop the rod into the curve and derotate the spine. But again, what are we trying to do? I know I'm showing you this multiple times over, but it's because these concepts are the basis of our reduction and fixation of the spine. Moving that concave pedicle posterior and lateral, okay? Such that these are the forces that occur. Our overbent rod on the concave side is pulling up. Our underbent rod on the convex side is pushing down. And we talked about rod bend out. Okay. Cantilever. This is predominantly, you can use a cantilever correction in a couple places. Most commonly, this is done to reduce kyphosis. So what you do is attach the rod into several levels. Tighten these up so that you're moving the block, and then you cantilever, pull this rod back into its position, and you'll push down on the spine. If you have good fixation and you've tightened these screws up here, the amount of force you put on the spine is really quite tremendous. And characteristically, this is what we're using it for, is kyphotic spines. I will attach 2 rods to this segment. I'll do osteotomies at the apex, and then push the spine down. Okay, the rods will be attached to these 4 levels, and will be sticking all the way up to here, and then we push them down into the lumbar spine. Now you'll notice it's corrected, but it's not corrected great. Now the reason for that is it's by design. I've only corrected this down to 50-something degrees because kyphotic spines tend to want to kyphose. If you get a patient like this too straight, that's where you end up with problems such as proximal junctional kyphosis. They will want to continue to kyphose. After we do all those reduction maneuvers, then we want to level our vertebra, top and bottom. We may want to further distract the concavity, and we can use compression and distraction techniques. And finally, direct vertebral rotation can be done as a segment or a block. So what does this do? Well, you get your both rods in and you find that you still have rotation or you have a large rib pump. We can then attach these devices to the pedicle screws, multiple levels, and we can derotate a block of vertebra. And you'll have to do this again in a stable or a neutral position so that you're rotating against one another. You know, so a block down here, a block up here, and then you can derotate. And when you derotate, then you tighten up your screws and that rotation will hold. So couple things here. This demonstrates, this is that same girl, Emily. So we have to do a little bit of a lever technique to reduce this lower lumbar curve. And then we're going to drop the rod in and do a rod derotation. So again, multiple techniques in every case. So here, levering it down, and I'm sorry, my arm's in the way there. So levering that lumbar spine. That lumbar spine is not lordotic, it's kyphotic and scoliotic. So we do our lever technique, get the upper end of the rod in. Okay, lumbar is in, attaching the top provisionally. And then we're going to rotate the rod into the curve. And when we rotate the rod into the curve, then we can provisionally attach those apical screws. There we go. Almost. All right. Are there any questions while we're watching this?
Yes, we have a
Okay.
few questions, but we usually take them at the end of the presentation.
Okay.
Yep.
So once again, we'll rotate the rod into the curve, provisionally attach each level, and then we're going to derotate the rod.
Sure. What's the most degrees that you have corrected during surgery by doing that? The greatest
Doing
amount, I would
this?
say. Yeah.
Well, as I said, we're doing multiple techniques in one surgery, so it's not like a rod derotation does everything. But I mean, we will routinely do 90-degree curves.
Oh, okay.
And when you
Wow.
start getting, 100-degree, I mean, you can do very large curves, but the correction is sequential. So, you correct first by putting the patient under anesthesia and positioning them on the table correctly. And then you'll do your posterior osteotomies and loosen them up further. And then you'll start doing these techniques. And so you're not doing 90 degrees of correction in one shot or using one method. It's
Correct.
okay. And then after you get your rods in, you'll do compression and distraction and get more. And then you can do some derotation and get some more. So it's not done in one piece. So here, like I said, here we are. We're dropping the rod into those curves. I mean, into the apical screws. And now we derotate. And again, this was the advance of Cottrell and Dubussé in the 80s, was doing this maneuver right here. Now, what does this do? It takes your scoliosis, translates it to kyphosis, and it does so in a way that spreads the loads. Because you're bending the rod, you're putting you're distributing the load across the entire spine instead of trying to translate one segment at a time. And spreading the load, spreading these forces is a concept that you need to keep in mind. Otherwise, you're going to be breaking bone and pulling out screws and so forth. Okay, so she's fully derotated and I'm locking it in the rotation in place now. Now, there's still a little bit of curve that I want to deal with, so we'll compress the lumbar spine. Why compress the lumbar spine? Well, we're posterior, so compression lordosis. So that's a convex side of the spine, and it's a lumbar. So I want to compress that lumbar spine. That'll kyphose and reduce the scoliosis. Whereas at the concavity in the thoracic spine, I want to distract. Distracting will reduce the scoliosis and will kyphose the spine, which is what we want in the thoracic spine. All right, so here I'm distracting that screw downwards against the rod being attached to the lumbar spine already. You notice there's a little bit curve in the apex. I guess I'm going back to the lumbar spine here. Okay, compression of the lumbar spine will lordose. And if you're on the concavity, which is where I started, I'm sorry, the convexity, we're going to reduce scoliosis in the lumbar spine. Now that screw is below the apex of the curve, so that's why I'm pulling it down. I'm reducing the tilt of that particular vertebra. This one is above. I think we'll distract us. Let me see what I. So if you notice, these maneuvers are continue to straighten the spine, don't they? And that was my point before. You don't get all the correction in one maneuver. Okay. And then we put our second rod in, and we'll get a little bit more correction and a little bit of derotation at the apex. And that's Emily finished. This case is actually almost 20 years old now. So our techniques are even better. Hardware and instrumentation is better. Now I'll be putting these screws in with the aid of navigation. So, so when we get up into areas where pedicle screw placement is difficult, by utilizing the intraoperative CAT scan and navigation, I'm able to get screws in at every level now. And look at the sagittal plane. Nice correction here. And this is what we want. We want a nice lumbar lordosis and thoracic kyphosis for sagittal plane balance, and to reduce that incidence of degenerative changes at the lower instrumented vertebra. And so this is her 6 weeks on her way to the prom. Rod bend out. So a frequent problem, one you have to address with by loosening up the spine, overbending the rod, etc. Look how straight this rod is. I did not put a straight rod into this spine. This is somebody who just took that cobalt chrome and flattened it right out. Look at the sagittal plane deformity of this kid. There's a reversal of the thoracic kyphosis and a flat lumbar spine. And this is a case I did with something called MORE. MORE is a new alloy. MORE stands for molybdenum rhenium, and it's a proprietary alloy of this company, Mirus. It is extremely stiff. It is stiffer than cobalt. And with that and some osteotomies, And some of those sublaminar bands that I showed you earlier, I was able to restore the sagittal plane balance of the spine. And that's important for longevity of this. It's also important because the child also has a spondylolisthesis. And if they're going to live pain-free with this spondylolisthesis, we need to get the sagittal balance correct. Just an example of a typical case, I believe. This is a large right-sided thoracic curve, our most common curve pattern. Standard pedicle screw construct. Do we need pedicle screws at every level? No, I put in more than you really need. Some surgeons will alternate and just put half as many screws in. If I have a level that's difficult to instrument, just leave it out. You just don't need it. What we need is an upper and lower segment that is strong. We need apical fixation that is strong. And this guy bent out the rods a little bit, but not terrible. I was still able to get the thoracic kyphosis. And the way you get that with a straight rod is by distracting these segments posteriorly and distract them upwards. And you can get a little bit more kyphosis than what the shape of the rod would allow. Early onset scoliosis. Here's a child who was at 7 years old, was failing their brace and progressing. Went up to 71 degrees at only 8 years of age. So I put in a device called MAGEC, M-A-G-E-C. This is a expandable rod. It's a growth rod. And the way it works is we use this magnetic device externally, and this drives a motor. Let me go back. There's a motor and a set of gears and a magnet inside the rod. And this handheld device spins that rod and set of gears and expands the rod. We do this every 3 months in the office. It takes a good 30 seconds or a minute, and we can get several millimeters of distraction, and it doesn't hurt the patient at all. And here is this young man, and if we look at the opening here in the middle, it expands and expands. We get them out to length. Generally, you can get growth for about 2 or 3 years, and then the spine starts to stiffen up to such a degree that they don't grow anymore. You can't get any more distraction, and you let it sit for a little bit for a couple of years, and when they're mature, we can go back in and do a fusion, take out all the growth rods and do a final fusion. New on the market, I've just started using this about a year ago, is something called ApiFix. It is a device that attaches at the bottom of the curve and at the upper end of the curve. These are universal joints, and there's a ratchet in here. So instead of us magnetically expanding it, the patient's motion and growth will cause this to ratchet out to length as they move and grow. So here's an ApiFix in place. Again, posterior, look, it's kind of kyphosing actually a little bit more than I would like, but this will be corrected later on after growth stops. Now, the ApiFix, according to the long-term studies and the European studies, is 85% effective in avoiding any other surgery in the future. So these devices should be one and done. They can stay in or they can come out at skeletal maturity. And that's it. Questions? I show this because this is 7 weeks after surgery. This was a dancer who went back to dancing. He was very proud of himself, so he sent me this email. And the purpose of this is to show you, this is our expectation in the treatment of scoliosis. I tell the kids, this is going to give you your life back. It doesn't hurt you long term. It takes that terrible large curve that becomes debilitating and gives you a normal life with normal activities going forward. Thank you.
Thank you.